Just a quick reminder to turn your cameras off. There we go.
Good evening, everyone, and welcome. I'm Maria Morgan, President of the British Association for the Study of Community Dentistry, or BASCAD for short. I'd like to welcome you to the 5th session in our series of masterclasses, our last for 2021, which aim to offer mentorship and key insight into public health, dentistry and strategic leadership for health from past presidents of BASCAD. I'd like to thank Peter Bateman for agreeing to share his career, knowledge and experiences in his presentation entitled Reconnecting Clinical Services with Dental Public Health. Thank you, Peter. I would now like to hand you over to Ross Keat to introduce this evening's masterclass, our early stage career council member and specialty registrar in dental public health, who has organised the sessions. Ross.
Thank you very much, Maria. So, as Maria says, this is going to be the last masterclass session of 2021. So, just thank you very much, everybody, for coming and for signing up and for allowing us to do these. Thanks as well to Maria for supporting me with this, and thanks to Peter for coming and speaking this evening. A few bits quickly of housekeeping. Just as I've said, the session is going to be recorded this evening. So, if you don't want to be made famous on YouTube, try to keep your camera off unless you have something that you want to say, and your microphone off unless you want to be heard. Yeah, so tonight we're going to hear from Peter Bateman. Peter is the chair of the British Society for Disability and Oral Health. He was also the clinical director for community dental services for 30 years in Sheffield, and was the BASCAD president in 2013. As Maria has already touched on, Peter this evening will be giving a presentation entitled Reconnecting Clinical Services with Dental Public Health. So I'd like to hand over to Peter to give the presentation this evening. Thank you very much, Peter.
Thank you, Ross, and thank you, Maria, for inviting me. I hope you'll be entertained, but we'll see how it goes. Can I just say right at the beginning that these views are mine and not the official views of BSDH, but anyway, that's keeping me occupied at the minute. Just bear with me while I share the slides, and then I'll be with you. If I put that one up, there we are. Very good. Can everyone see that? Is that visible,
Yep.
Rob?
Yeah, that's perfect.
That's good. Thank you. Right. So here we are with today's objectives. I think it's fair to say that clinicians have drifted away from BASCAD over the last few years. If you like, the old guard retired and a new guard never replaced them. So I'm going to start today's presentation with the CDS, take a brief dip into paediatric dentistry because it's a key part of the CDS, and then later on move into special care dentistry, and then start exploring what opportunities there might be to get dental public health back into special care, or clinicians back working with BASCAD, because I think the time is now right where we need to start working together in a way that we perhaps haven't over the last 10 years or so. So I'm going to take you back till 1985, because that was when I joined BASCAD. I was a master's student with Aubrey Shire at the London, and you couldn't be a master's student with Aubrey without being part of the BASCAD family. And then I moved to Sheffield in 1985 and joined the CDS. And the CDS back in 1985 looked very, very different. We had district dental officers. And district dental officers did everything. They sat on the LDC, they sat on the hospital boards, they ran the CDS, they advised the health authority. There was a lot of dental screening going on. We were in the very, very early days of the BASCAD epidemiology surveys. So BASCAD had produced the protocols and they'd produced Dental Survey Plus. There were strong oral health promotion teams, of course, but we were all together within health authorities. There were no service contracts, there was no competition, and there were no cost improvement savings. And as Tom Dowell proved at the time, as long as you kept your head down and you sent your figures into the department every year, you were just allowed to get on with it. In actual fact, for those many younger, probably haven't heard the Tom Dowell story, one year he sent the same figures in, precisely the same figures as he sent the previous year. And no one batted an eyelid at the Department of Health, so he did it again and still not an eyelid. So the year after, he decided he'd wake them up, so he put a deliberate mathematical error in. And many months later, he got a call from the department to say there was an error in his figures and could he correct them. But no one had still noticed that he sent the same figures in year on year without anyone noticing. Anyway, we then started a period where the CDS and the dental public health began drifting apart. I've put HC 8902 as the first of these because that was a key document that was produced by the Department of Health, which basically introduced to the CDS the issues are the role of providing special care dentistry and dentistry for adults who couldn't get dentistry anywhere else. Until that time, the CDS was largely not changed greatly since the old school dental service of 1974. One or two services had begun to see small numbers of adults, and one or two services had done an odd domiciliary visit. But basically, it was 89.2 that began to change anything. We then had the purchaser provider split, and that separated off our district dental officers, who by that time were specialists in dental public health, from our CDS, and the CDS created the clinical director role. Move through the 90s, and the National Screening Committee reports that there is little evidence that routine dental screening has any effect whatsoever on the dental health of kids. So that most CDSs at that point in time took screening out of their programs, except perhaps in one or two identified hotspots and perhaps special schools in our patch, but that was about it. Then, of course, we move into the formation of the dental specialties and the specialist societies. And what happens then, of course, is the clinicians see their specialist society as their main home rather than BASCOD. So quite a lot of clinicians at that point probably only had time, and organisations are beginning to cut down a bit on study leave. So at that time, the first choice was probably the specialist society, and the second choice was probably CDS group, and BASCOD began to not attract the clinicians. Then, of course, we move into the 2010s and we get Andrew Lansley messing everything up. So dental public health left, in England at least, left health authorities completely and went to local authorities. And the CDS went into much bigger organisations. And to be honest, there are community trusts about, and of course we have one large social enterprise, but most CDSs nowadays are in acute trusts. BASCOD had its service and development and delivery section, but it was becoming hard work. I know Leon and Zotopoulos and I did quite a piece of work on trying to put a catalogue of resources, an index of resources for CDS clinical directors together, but it was becoming very hard work by then, and the service development and delivery section, to be fair, was beginning to die on its feet. But the one thing that kept the CDS, or the two things that kept the CDS and dental public health together, were all health promotion and the dental survey programme. But we then went through a period of odd experimental surveys that didn't necessarily involve the same teams. For example, in Sheffield by that time, I'd decided the best way to manage the surveys was to employ an old retired dentist as my one surveyor, and they had a 0 hours contract, and about 3 years in a row did a very good survey and nice and efficiently. But then we had a survey they couldn't do, so they weren't involved for a year, and at that point they decided to retire. The other thing happening in the CDS at that time was the number of Band-Aid dentists were beginning to go down. As the CDS was moving more to specialised services, the Band-Aid dentists weren't needed as much. So yes, it was the starting point to get people into the more senior roles, but essentially Band Bs and sometimes even clinical directors had to become involved in the survey, so it became more expensive. Surveys disrupted clinics because, of course, you had to cancel books and then you had to go back because you didn't get your 85%. And one way that our consultants in dental public health tried to tackle this was smaller samples, but that really didn't work because, particularly for the children's surveys, fixed costs are very high, which are getting out to school, setting up in the school, organising the kids and getting back. Yes, in sort of medium to large size primary schools, you might manage to get 2 schools in a day, not 1. But for most schools, and I remember one year I did all the surveys in Bassetlaw, a very rural area in North Notts. And we were chasing around North Nottinghamshire doing 5 schools a day, and we weren't going to get any more than 5 schools a day, however big the sample was. We might as well have see them all. The other thing that began to happen, of course, was NHS England began to flex its muscles. So the NHS England contract very much became the key focus of the CDS, and the surveys, and to some extent in some areas oral health promotion, began to be very much second fiddle. Then they had the bright idea of competitive tendering. Well, that really went down well in my part of the world because they decided to combine the 4 South Yorkshire authorities into one bid, but only pay us about 1.5 times the original cost of one area's tender. Well, needless to say, no one bid. They tried it again and no one bid again. So that was it. The surveys weren't in the CDS anymore. And much as thanks very much to the hard work of Zoe Marshman, in Sheffield ourselves, we managed to retain the confidence of the City Council in the Oral Health Promotion Service, and that remained a key part of the CDS. To be honest, we were the exception, not the rule in our part of the world. And most oral health promotion was moved out of the CDS and into local authorities. So that was it. Surveys gone. So what have we got left in 2021? We've got a CDS that very definitely needs an NHS England contract to achieve, very much focusing on level 2 and 3 care, and in theory not taking level 1 patients, and in theory, but I'll come back to this later, passing patients who can be treated by the GDS back to the GDS. The host trusts have become larger and larger. So the host trusts actually call all the shots now. So, for example, when you negotiate with the CDS, you're negotiating with a large trust that really doesn't have the interests necessarily of the CDS as its priority in the way that perhaps in the old days we were. CDSs have become led now by specialists, often without any management experience. Back in the late 80s, I was very fortunate to be sent by Roger Easterman, my boss at the time, on about 3 or 4 excellent management courses run by the BDA, all costing the best part of £1,000 a time. And that gave me a wonderful background to run the service, but none of that happens now. So we've got these specialists who've really not done much management. Quite a lot of non-clinical managers about. And of course we have financial targets, and whatever NHS England says about our budget is set by the Home Trust, and it might, if NHS England saw what the budget of the CDS was, they might not recognise it. So yes, patients are meant to come first, but to be honest, at times finance comes first. Oral health promotion and epidemiology are certainly very minor considerations in the overall scheme of things in the trust, if they exist at all. And then, of course, just to top it all off, we've had COVID. Just before I go on to special care dentistry, as I say, the CDS really has 2 main specialties in it. And the other one is paediatric dentistry. And I want to say, from a CDS point of view, the paediatric specialty is absolutely dominated by the dental hospital consultants. They control the training, they control recruitment, and they control the MCNs. In the last month, I've had a conversation with a commissioner in a region of the country that I'd better not name, who's tearing her hair out because she's seeing these specialists that Health Education England are put through training, coming to the end of the training, and she's seeing the acute trust with the dental hospital as they come to the end of their training, creating a business case to make sure that they stay put where they are and not go down the market, out in the market. So you've got well-served, in paediatric dentistry, you've got well-served areas in the immediate hinterland of a dental hospital, though the patients still have to go into the dental hospital in most cases. And you've got large areas of the country with no specialists at all. Specialist recruitment in the CDS is often impossible. And the dental hospitals are perpetuating this far away from the children that need them and their homes and the schools. And I think the only answer is to try to incentivize the trusts, whatever the new format of contract is, to kick the consultants out of the hospital. We actually did it in Sheffield in the last years of my time there. Luckily, we had a really community-focused interest from one of the specialty registrars in paediatric dentistry. And she started up a hospital clinic in one of our community clinics in a deprived part of town, about 4 or 5 miles and 2 bus journeys from the dental hospital. And we selected the patients from the hospital referrals so that by postcode, so that they were relatively local. And what did she find? That the DNA rate went down from about 15% to about less than 5%. And she got lots of comments from the parents to say, it's great, I can actually drop her off and go and get the other kids from school, etc. It is no longer a whole day out to come and see the consultant. And that has been built on because we had a capital building programme, and actually at that site, creating a hospital clinic within the community dental premises, running hospital dental services to a hospital contract. But that is a real rarity. Too many kids in too many parts of the programme have to take their days off school, and the parents have to take the days off school and find childcare just to travel miles and miles and miles to get specialist opinion. Right, that's my rant about paediatric dentistry. Let's move on to special care dentistry. Special care dentistry, of course, developed in a different way. So in most areas of the country, it's always been CDS based, and most of the training programs have also had a large CDS element. 1 or 2, perhaps around London, are a bit more hospital based, but in most areas of the country, a large CDS element. Obviously, we were all going through or getting to the end of the programme at the moment of redrawing up the criteria for trainees in each of our relevant specialties for the GDC. But however you redefine special care dentistry, it is a huge, broad spectrum, and it's quite difficult actually to make it short and succinct. I mean, the 4 main areas are there, but that leaves out the likes of the physical disabled and the bariatric, for example. So, you know, a broad spectrum. There's a huge question mark about who meets the acceptance criteria for special care dentistry. How do you refer and who refers? And there's some fairly bad practice going on in some parts of the country. I've heard that in one area, patients have to be referred by a dentist. Well, they can't get if the patient meets the criteria for specialty care and special care dentistry, they probably can't get into the general dental practice, and they get sent out straight away again if they could, because the general dental practitioner would just have no chance of seeing them. In my service in Sheffield, well over 50% of our adult special care patients came from sources other than dental sources. So GPs were a large referrer, carers were a large referrer, nursing teams referred to some extent, and a whole mishmash of others, but social services. But dentists themselves were a relatively minority. And I'll say a little bit when we come to discharge about acceptance criteria, but it's not absolutely straightforward, because we're not talking about something that's technical here. We're talking about something relatively subjective, the difficulty to treat. So what one dentist can manage reasonably well, another dentist just can't. And we're not talking about extractions here, where you could argue that all dentists should be able to extract teeth. It's all about being to empathise and get the confidence of the patients and the carers, and make decisions about the challenging behaviour, for example, that you're meeting. So it would be unreasonable to leave the patient out because they were in a dental practice that was struggling to manage them. And the last thing we would want to do is say, this are the acceptance criteria, you've referred by this dentist, go back to the same dentist, because that ain't patient friendly. They're not going to get treated there if they've once been referred there. The second question is, what is a reasonable cost? Special care dentistry is very expensive because a lot of time it's spent working with the patients. With the mental health group, I've always argued that the higher the DNA rate, the more we're actually focusing on those that we ought to be focusing on. And obviously domiciliaries are expensive, but I'll say a bit about domiciliaries in a minute. But costs for the most challenging patients are high. UDAs aren't relevant. There is no reasonable background at the moment or basis to set any cost per case costs, because no one's done the work on it. So it's quite difficult to establish what is a reasonable cost. Just interestingly, as an aside on domiciliary care, we also had another little experiment in Sheffield. We decided that all domiciliary referrals and all those patients seen on domiciliary at the time would be pre-assessed by a hygiene therapist before they saw the dentist. The hygiene therapist went, one, to get a lot of the data that was needed, the demographic data, the medical history and all that, to save the dentist time, but also to assess whether they needed domiciliary care or not. What we discovered in our little experiment was that just something like 60% of our current patients and a similar proportion of new referrals didn't need domiciliary care at all. They could get to the dental surgery. So they were actually denied domiciliary care and told they were coming to dental surgery. The main reason was they were normally getting out of the house for something or other else, like the hairdresser or whatever, quite easily. So we made the decision that we were going to really toughen up on the acceptance of domiciliary care. We actually moved it on in due course because we actually discovered a dental nurse or two, a couple of dental nurses could do the job as well as a hygiene therapist and a dental nurse. So dental nurses do that job now. Then you've got the problem of discharge. If the CDS keeps accepting everyone with, that meets the acceptance criteria and never discharges anyone, they're going to get overwhelmed. But the reality is that there are patients who will never be able to treat it anywhere else but in a specialty area or a specialist-led service. And who do you discharge to is a real issue, because the system really does not facilitate discharge. And as you will see when I come further on in the future slide, we've got to design a system which doesn't penalise either a general dental practitioner or a CDS for sharing the care of a patient so that they can go to one, go to the other. So maybe have routine checks in one, but a scaling maybe, or even any restorative treatment or anything in the other. The minute if you start doing that, one or the other, the practitioner or the CDS, will soon have Eastbourne on their back because they're treating patients that have recently been treated, keep being treated in other places, and one of them will be on their back. So we've got to start somehow creating a shared care system. The other big issue for special care dentistry at the moment is where is the evidence base? Because special care dentistry, of course, is 10 years behind the other specialty. Most, not all, there are some dental schools with an academic department, but most of the dental schools don't have an academic department of special care dentistry. So the evidence base is actually relatively scant. So here are the current priorities for special care dentistry. The first is GA accessibility. COVID has really shattered the treatment plans of those that require general anaesthesia for treatment. And general anaesthesia, comprehensive care general anaesthesia, is not an economic means of using theatres in an acute hospital. So GA accessibility in some parts of the country is really, really tricky. There are good parts of the country. I hear that Nottingham, for example, have got an excellent system, and there they don't have any waiting lists. But we've come out of COVID in many with huge general anaesthetic waiting lists in many parts of the country. The second problem is no one actually knows what's happening. I mean, I assume that most BASCOD members have seen the GIRFT report. And you will have noticed in the GIRFT report that as far as hospital episode statistics are concerned, virtually every acute hospital in this country regards special care dentistry as something else. So we don't have any special care dentistry going on in hospitals, even though there's a heck of a lot of special care dentistry going on in hospitals. So one of our priorities is actually to get the hospital data sorted so the specialty codes for special care dentistry are used. One of the challenges, as much as there is a specialty code, no one's actually ever attached any finance to it. So it's all got to be locally negotiated. The next one is about commissioning CDS and hospital special care dental services together. I always felt that it was completely an issue that when we talked about the CDS, I would come up and I'd talk to the commissioners and we'd have a commissioning meeting about the CDS and agree our priorities and whatever. But going on in the background was the other part of my service, the hospital service, having a separate commissioning meeting that no one in special care dentistry, not me as clinical director or any of the special care consultants, were involved in at all. And of course, I'm afraid in some parts of the country, commissioners left it up to the CDS to negotiate their access for general anaesthetic in a hospital trust where they weren't both part of the same organisation. And a little community trust really does not have much say or weight when it comes to negotiating with a hospital trust for theatre sessions. I mean, the big question at the moment, are ICSs going to help or hinder special care commissioning? It would be nice to think that they might help. Let's wait and see. We need some better flexible commissioning. ROCS, which many of you might have heard of, residential oral care in Sheffield, were actually developed pre-1996. It was actually developed in the time where every item in the GDS had a price. And it was negotiated for general dental practitioners to take on all the elderly care nursing homes in Sheffield, and they got an allowance for doing it. And the whole programme was led by a CDS senior dental officer, later specialist, and they had a team of general dental practitioners who basically screened the nursing homes, did whatever treatment they could, simple treatment they could, and referred anything that needed referring. That system survives to this day. It actually said predated UDAs, but it managed to get negotiated a UDA allowance for doing it. So it carries on to this day. And it's had lots of presentations around the country, but it's never really taken off anywhere else. And that is because you actually need flexible commissioning to make it happen and make it worthwhile for the GDPs to do it. And whereas Sheffield has set the model, no one else has actually worked out that you've got to give a bit to make it happen. I've already talked about shared care models earlier, so I will move on to that. And I've already talked about referral systems, and they've got to focus on the patient's needs and not necessarily some mathematical formula. Patient charges is a real issue that's one of our priorities at the minute. We seem in this country not to be able to manage patients who don't have capacity when it comes to the patient charges. And of course, just before COVID, we had a period of time when there was a load of bad publicity because loads of patients without capacity were getting fined. Now, Charlotte tells me that the BDA have had to put this one to bed a bit during COVID, but we'll be bringing it out again because it's not been solved. We have a very good system in the country for dealing with patient consent. And we have the patients without capacity. We have this great system that works, and we deal with best interests, and we deal with powers of attorney, and we deal with patient consent, and it generally works. But a carer brings to the patient to the CDS. The carer has no idea whether the patient has to pay or not. The patient doesn't know, and nowadays with the big corporates in the care sector, often the local home doesn't know either. And in theory, if we were to follow the rules, the patient would be denied treatment until time was taken for someone to work out what the financial issues around this patient without capacity are. So somehow we have to have a slick system that, like we do with consent, that accepts that patients without capacity don't know what their financial status is, and they should be treated for free until it's been proven otherwise by the department, and not the other way around. I've already said there's a huge priority for developing the academic side of the specialty, because that really is something that is still very much in infancy. And then I'm going to say a little bit about case mix, because of course case mix is my baby, and we need to use it properly to understand case mix properly. Case mix started way back in the days of valuing people with oral health, which people will remember from that era was a major series of Department of Health publications on people with learning disabilities, of which valuing people's oral health was just but one of a number of publications. And apart from this quote, there was a quote in valuing people's oral health to the effect that we needed to measure patient complexity. And Janet Clark, who was chair of the relevant committee at the BDA at that time, asked me to chair a working group to begin to build on some work that we'd been doing in Sheffield to try and assess whether there was a methodology for measuring patient complexity in special care dentistry. And we ended up with the BDA case mix model, which has 6 criteria. I'm not going to give the details, and people can write to me afterwards if they want the details, or find it on the BDA website. But we have 6 criteria. Each criteria is a 0 ABC scale, where 0 is a standard patient and ABC a more complex, increasing complexity, all supported by narratives to try and help describe. The criteria are weighted. There's a bit of help in the system for analysis, and there's a bit of help for benchmarking. Why is it not moving on? What have I done? There we go. I don't know why that didn't move on. Sorry. So these are the 6 criteria. We have moved on now. We're in the 3rd iteration. Charlotte Waite and the English Community Dental Service Committee issued the third iteration just before COVID. But the third iteration, the structure of the model is exactly what it always has been. All we've done is we've tried to, as a result of work that's been going on and people using it, tighten up and modify slightly the narrative. One of those pieces of work was actually done by your president, Maria, and that led to some of the changes for the second iteration. But however hard we try, there is no doubt that the case mix model is still not perfect. It's the best that we can have. So it is definitely not a contract currency. How the London CDS contracts, and I don't actually know whether they still do, but they certainly did, can link money to case mix when there has been no evidence whatsoever to support such a move, I don't know. It's definitely not a measure of complexity of dentistry provided, and we've had arguments with paediatric dentists on that one in the past. It's a measure of the patient and not the dentistry. Nor is it a direct measure of the time taken to treat a patient or a mathematical formula for calculating UDA credits. Yes, it has a subjective element, but it is the best we've got, and it's better, you know, that is as good as we're going to get. It is, you could say it's qualitative, not quantitative to some extent. But one of the things that happens is the CDS dentists underscore because their normal is different from the original baseline normal. So anyone with a score of at least 1 has some complexity. Commissioners misuse it by adding all the scores together, but it isn't an arithmetical model. So someone can score very high on one of the criteria and therefore have a complexity that needs a lot of effort, but score low on or 0 on all the other criteria, and therefore, in the commissioner's mind, not be complex at all. Whereas in actual fact, on the one criteria, they are very, very, very complex. And despite some of the changes we've made, there are still some things about the model that we know are just inbuilt, not biases, but things that you have to be aware of. We know, for example, that children still score lower than adults, and that will always be the case. And that some adult conditions, such as mental health, still score low, but it's very difficult to actually bring them up to the same as some of the others. So, yes, it's a really, really useful model. But the grand total is not the be all and end all, and it has to be used carefully, and commissioners have to understand what its weaknesses are as well as what its strengths are. Right, so if you like, it's now widespread use across the CDS in most of the UK. It's been used, so most CDS are using, not hospital services. It's widespread use by the commissioners. It's the recognised system of acknowledging the challenges that special care patients bring to dentistry. It's been used for benchmarking. It can be used, it's been used a little bit, like by your president in research, but not a great deal. And the trainees actually use it a lot. The trainees very much use it to describe the complexity of their cases. So I think the thing about case mix is it's if you like, it's sat there waiting for someone to begin to develop more of the evidence base to broaden its use for things like perhaps discharge planning, perhaps acceptance criteria. I know Nigel and Maria were beginning to do a bit of work on that, but that, you know, that if you like is where we're at with it after about 10 years of use, 10 to 11 years of use. Let me conclude by coming back to the original question, and I'll start by bringing strategic planning into special care dentistry. How does special care dentistry need to move forward? Well, the first thing that happens is you get a better understanding of what services are provided now. There is virtually no dental needs data in special care dentistry. Unfortunately, because of the issues of consent, most of the very few surveys that have been organised by BASCOD in this field have probably touched on the very much more moderate end of whichever disability they were talking about, and really haven't captured the patient needs and the needs data. And perhaps a survey isn't the way of doing it, but you know, if the Eastbourne, the BSA could be persuaded to collect the case mix data, and it's there in the computer because I can't even finish a patient off unless I put the case mix in. If the BSA could be persuaded to collect this, there must be a wealth of data at the BSA that could begin to look at needs data for special care. It needs some academic leadership because, as I say, most hospitals, dental hospitals, still don't have academic departments. We definitely need to listen to the voluntary sector more than we've had in the past. It's very difficult because they're quite often quite difficult to engage, and we really do need to begin to listen to the voluntary sector more than perhaps we have done. It's definitely doesn't want to get down the route that paediatric dentistry has, where it's all delivered centrally. It still needs to be maintained and strengthened at a local level, because if you've got a challenging patient, it can be quite tricky to get them to a large distance. And if you're in a big transporter with a driver and a wheelchair taking the carers to the driver, trying to park up at a big acute hospital in the middle of a city centre ain't necessarily the easiest thing to do. And somehow we've got to incentivise NHS Trust to do the right thing by the patient. So reconnecting clinical services, let me come back to where we started. Reconnecting clinical services and bringing CDS clinicians back into Mascot. You'll see I put X's against epidemiology and OHP because I think they're past it. I really don't think that we're going to get anywhere if we follow on down that route. I think they've got other priorities. There are a few clinical leaders in CDS that would benefit from the wealth of knowledge that Mascot can bring them, but the numbers are much lower than they used to be. So I think we've got to start thinking in these other areas, working together to work out how CDS can complement the GDS in, for example, shared care. Giving the CDS a voice, or the patient, not the CDS, the patient a voice in special care, in secondary care, for example, in general anaesthetic services, and supporting CDS-based research. So as far as reconnecting from a special care dentistry perspective and from a BSDH perspective, I would like to see involving the specialist societies in needs analysis planning, and we certainly need some of it in special care dentistry. I'd like to see some support for by academics to get an academic base to the specialty, because we're starting from scratch. I'm suggesting that it would be possible for BSDH and BASCOD to put together a joint working party to tackle these current priorities. And it has been suggested in my committee that we perhaps move towards a joint conference. And I know our 2023 president would be very keen to share the December 23 conference if BASCOD were wishing to do that. So with that, I think that's enough of me. Let me pass back to Ross and ask there any questions that you've got.
Thank you. Oh, thank you, Peter.
Brilliant.
Hello, Ross.
Just getting a little bit of feedback here. There we go. So Peter, just to start the questions, I think a few have come through in the chat as we've gone along, but certainly there were a few sent in as well as part of the sign up. I see Debs has just commented. I was actually going to ask you Debs' question here, which is, do you think that community trusts in England have lost access to DPH advice and skills now that most DPH mostly advise commissioners? If so, could CDS trusts employ DPH consultants for a few sessions per week or month? Just need to unmute yourself, Peter, sorry.
In theory, yes, but whether it would happen on a formal basis, I'm not sure. I mean, I suspect that the big social enterprise trusts, CDS, CIC, would very much welcome such an initiative because it would give them a bit of a competitive advantage if we're still in a mode of beginning to bid for services. But I think, to be honest, dentistry, never mind CDS dentistry, is such small fry within the acute trusts that I think it could be quite challenging there. I think it's a great idea. And I really think that dental public health consultants and teams should spend more time with clinical services and particularly with CDS services than perhaps they have done in recent years. But I suspect, at least to start with, it might be easier to organise on an informal basis with your local service leader rather than trying to involve the bigger trust.
Thank you, Peter. I noticed that Charlotte Waite has asked a few questions in the.
Not surprised.
So just wondering if Charlotte wanted to ask anything herself, or if you're happy for us to read them out, Charlotte.
Hi, can you hear me?
Yeah, I can indeed.
Nobody else was chatting. I was chatting. Anyway.
Charlotte, just to say, I deliberately sent that to you to get some comments beforehand, but you didn't realise it. But anyway, not to worry. Let me take the flak now.
Oh no. So I think I asked a few things as you kind of went along. One of them was about management. Sorry, that's the dog and the children. Management courses for CDS dentists. Sort of thinking whether that might be something to think about again. Or your opinions on nurturing leadership in the CDS, because we've got the fellows around, but is there something else we could do to sort of nurture leadership and management within the CDS again? Just wondered what your thoughts on that were.
I can only go back to where I got all my learning, Charlotte. My learning came firstly from some, obviously the master's courses I did. Master's course with Aubrey, and you can't have a better master's teacher than Aubrey to make you start questioning everything. Then from the courses that the BDA organised at Wast Hills in Birmingham, but then I suspect that's too expensive. But then, and most importantly, from a learning set that was set up by clinical directors in the West Midlands, and the likes of myself and Stephen Boyle in Cardiff joined. So the likes of Jane Davis-Slovak, Janet Clark, Margaret Guluska, for example, all having done their master's courses in Birmingham, set up this learning set. And we actually learnt one heck of a lot in a learning set. And perhaps the simplest answer to your question, Charlotte, is to try and set up learning sets with experienced managers and the young, because that wouldn't cost so much. It wouldn't cost trusts much more than a bit of time, which hopefully they would give, and we begin to get managers who actually had a bit more. I mean, that learning set has given me the mentors that I've looked on for the whole of my working life. So I think that's where I'd begin to start looking.
Thanks, Peter. Yeah, it sounds very valuable. The other thing I was talking about is what other applications do you think there might be for case mix? Just thinking about dental system reform and whether or not, I mean, I've often wondered about case mix, taking it to our actual medical colleagues, obviously not quite so dentally orientated, but the concept of case mix and taking it out of CDS and wider application, just wondered about your thoughts on that, Peter, and then I'll be quiet.
Yeah, I think we could take it to special care dentistry in the hospital, and I think that would be useful. I've always been reluctant to take it to the GDS because I worry that the GDS, and perhaps this is a bit unfortunate, and I shouldn't be saying it, but I do worry that the GDS might manipulate it in a way that wasn't to the benefit of them, not to the patient. Whereas I think the CDS certainly generally underscores. I'm not sure that would be the case, but maybe I'm doing our GDP colleagues down. There was conversation at one point about taking it into podiatry, and I know I had one or two local podiatrists that were interested, so that certainly is a possibility. I think if we want to use it in a wider way, I'm not saying you can calibrate people, but you've got to do some research to give it an evidence base. So I'm not for 1 minute saying you know, if case mix is going to become the basis of a payment system or a basis of a bonus to the payment system to manage complexity, and I wouldn't rule that out completely, but if you're going to do that, you've got to get an evidence base to do it rather than start just doing it like London did with no evidence whatsoever.
Thanks so much, Peter. Thank you.
Maria, you're on mute.
Yeah, I just realised. Thanks, Peter. I have a question, but my question is going to be in the context of my work in Wales, where we have an all Wales community dental service, and my career has been very much involved with the epidemiology programme, and the people who are key to that are the CDS, and again, Design to Smile, Gwen and Biff, our care home initiative, and we have the CDS. So I saw the crosses against OHP and the crosses against epidemiology, and I know perhaps you could expand on that and why that might not be a goer in England so much, because to me, I've seen, you know, the CDS as this public health in action service, and crucial to the fact that appreciating the data that's being collected and what it's being used for, and then how that's used for needs assessment, which you mentioned, and then the health improvement programs. So I think
the arrangement in England has been much more passive as far as the CDS is concerned. So we have delivering better oral health, and there is no doubt that the CDS used delivering better oral health, but they were no more involved in producing it, let's say, than any other part of the dental profession. So it's generally something that's arrived as an evidence base on the table and has then been used. Now, the reason I put the crosses is because, as I said, CDS are largely either involved in epidemiology to a minor extent or not at all, but it might be one person regionally now who's doing most of the epidemiology stuff. So I don't think there's enough people. In the old days when the DDOs were there, everyone in the CDS had a public health bent, but most of the CDS dentists are now most of their time clinicians interested in clinical delivery, and most of the contract is about clinical delivery. OHP, I think I'm one of the very few patches I know who still has OHP as a key part of our CDS management team. They were certainly the only one in South Yorkshire. So that's why I put crosses, because I think that's what to some extent Bascod's been trying to do for the last 10 to 15 years. And it hasn't really attracted them in England. So I'm sort of beginning to think, whether we like it or not, and in an ideal world like Wales, then it might work. In bigger England, we've been there, tried it, and it's not working. So we've got to think outside that box and try something a bit different.
Yeah. Thanks very much, Peter. And collaboration between the two societies, I think, you know, rather than dilute the messages and the actions, working together is important. So thanks for that slide. I will take that on board.
Yeah.
There's a question here from Eric Rooney. I'm just wondering if you wanted to come in and ask it yourself, Eric, or if you're happy for me to ask it.
Yeah, thanks, Ross. Hiya, Peter.
Hi, Eric. You all right?
Yeah, fine, thanks. Can you tell us a bit more about your thoughts on ICS PCN? You mentioned it earlier on, and kind of like the world of integration, big focus on clinical leadership and all that sort of stuff. I think that's where the action's going to be, and I think there's potentially a leadership role for Bascod, but I'd be interested to hear your thoughts.
The first thing I would say is that ICS became bigger after I retired, so I might not be totally up to speed on ICS, so obviously the pilots have been going on around the place for quite some time. My gut feel is that in a trust where dentistry is what, 1% or 2% of the revenue, and 2/3 of that is in a dental hospital, we're going to be minor players, and I just worry that in the bigger ICS, while we're in those organisations, we're still not going to really get much of a say, and it's still going to be the ICS dental commissioner talking to the dental team and nothing much beyond that. But maybe I'm being negative, Eric, but that's just my worry, is that in the bigger scheme of things, in the big trust, dentistry is too small a player to actually, it's going to make a lot of difference. But as I say, I'm not up to speed, so maybe I'm wrong. I don't know.
Thanks. I just wonder if, you know, BASCOD as an organisation stretches across with the dental public health bit and the clinical bits that you've mentioned and given us the history about. There's, I think, a bit of an opportunity for BASCOD to kind of marshal some of the resources and expertise and whatever, because as a pile of individual dentists, we're probably not going to make a big impact, like you've just said. But I think there are some opportunities in working across and with the specialties to ensure that actually dentistry gets its rightful place in the new architecture. And one of the key things is the focus on clinical pathways which go across primary care, secondary care, specialist care, etc. And I think, you know, there's an opportunity if we just worked a bit smartly, and we can't do it, I don't think, from the centre nationally, but in each of our ICS areas and regions, we need to kind of think in that sort of way. And maybe there's a role for BASCOD to help support.
I couldn't agree with you more, Eric. In a way, you've said quite a bit of what I put in the last slide in that bit. You know, I think this is the way forward. We have to work together. And I say I couldn't agree with you more, but we've got to do it locally as well as some national leadership. Yes.
Absolutely. Thanks, Peter. Nice to see you.
I've just got a really quick question as well, which I think sort of leads on from what Eric was saying and sort of a bit of the content of your presentation as well, Peter, just relating to the attrition of specialist societies. And I know it's something that Maria and I have spoken about, sort of possibly, you know, across society membership. So, you know, as a registrar in dental public health, BASCOD is my specialist society, but I have an interest in paediatric dentistry and, you know, the underpinning issues which cause inequities in paediatric cohorts. So it would be a benefit to me to attend BSPD meetings, for example. But obviously, being a member of two specialist organisations is both expensive, and you, like you say, you don't get the academic leave for that sort of thing anymore. So do you think there would be any benefit in sort of having a, you know, cross society membership, or some way of having, you know, friends of these societies, which would enable you to attend possibly events, conferences for a lower cost, and increase the you know, the size of our voice as a collective of organisations?
I mean, it's worth exploring. I think the issue is getting the time to do it. You know, in my day, we were always away on study leave with one day anything, because apart from the societies, we had a few. The older ones will remember a few enterprising DDOs like Mike Marchmont, who ran their own study days in Staffordshire that we all poured off to as well. So we were always seeing each other on study days, but getting study leave in those days was never a problem. I certainly would commend people being members of more than one professional society, but I don't have the answer to how you can get the study leave to actually make it happen. And I mean, I'm a classic example, because I'm no less a BASCOD member now than I was 5 years ago, but I've probably not been to a BASCOD meeting for about that time, because I've only been able to get enough study leave to keep BSDH going.
I appreciate, and I suppose it's, and you know, not just the conferences, but sort of evening events as well. Sorry.
Yeah, I agree, because I think there's, you know, going forwards, once everything settles down with COVID, we'll have some sort of hybrid of, you know, conferences and virtual events which people can join in on. And related to that, I think Morag has a question to put into the chat. Morag, would you like to ask the question?
Yeah, thanks. I'm just reflecting on what you're saying, and I completely agree with the the benefit of sort of bringing the specialties together. And the question I've put in is kind of, is there a role for hybrid dental public health, special care dentistry roles to kind of bring the specialties together, which I suppose is possibly what it was like 20 years ago, and then the specialties have kind of driven things apart. And I say that as someone who spent most of my career in special care dentistry and then has moved into dental public health, so I've gone from one to the other, rather than, you know, is there a possibility for a sort of joint role so that I could have done both throughout my whole career rather than doing one then the other?
That's to a large extent, Morag, is what used to happen in my younger days. So, you know, the specialties have moved us away from that, and I think it's up to us if we want to get joint roles. I don't see why. I mean, one of the problems is we're tied down by the GDC, who thinks in boxes, and that's going to be a challenge we're going to have to overcome when it comes to specialty curricula. But I think we've always felt in special care dentistry that we have to be able to do many of the other clinical specialties anyway. And if we're going to get any decent needs analysis about the needs of our patients, we're going to have to do some dental public health as well. So I think there will be a will there to work across specialties. I think we've got to somehow break those boxes down, and perhaps it's going to be difficult to do it formally because of the way the GDC is operating the specialist list. Perhaps it might be that the specialty societies have to do a little bit more working together, like I've suggested, so that we actually step a bit onto each other's territories.
Thank you very much, Peter. So I think because of the time, we're going to move to just close the session. So I'm just sharing my screen now. I do this at the end of every masterclass session just to make people aware that this is an event which has been put on by BASCOD. I'm aware that not everybody here is a member of BASCOD. If you'd like to keep attending events like this, or if you'd like us to keep being able to put on events and you know, stop this attrition of specialist societies that we've spoken about, it would be great if you could join. There's a QR code in the top right corner. There's information on the BASCOD website. So feel free to explore that at your own leisure. I think it's important as well that we talk about BASCOD being the Specialist Society of Dental Public Health, but dental public health isn't just for dentists and dental public health clinicians. Indeed, membership isn't restricted to those with a clinical qualification. If you're interested in the improving community oral health and addressing the determinants of poor oral health, then please join BASCOD. And you know, we're a lovely bunch. So I'm just going to hand over to Maria now just to close the session. Thank you.
Thanks, Ross. I'd just like to say thank you very much to Peter for your great masterclass tonight, which stimulated quite a bit of discussion. And I really do hope that we can work across specialties more and work together, because, you know, we all believe in prevention is better than cure, and also it's important that we have decent dental services too. I'd like to thank Ross for helping to host and also to organise the sessions, which I think really, from the feedback we've had already, has been a successful venture, and look forward to more next year. And I would like to wish everyone online in the run up to Christmas a happy Christmas and a happy New Year for the new year next month, and hope to see you sometime in 2022 for more masterclasses and collaboration with our colleagues and friends. But thanks ever so much, Peter. I remember your conference in Buxton with fond memories and great learning, and thanks very much for tonight.
Thank you.
And thank you everybody for joining us. Some lovely comments in the chat saying thank you. So thanks everybody, and we're going to sign off, I think. Thank you everybody. Bye.